Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Today's podcast will focus on multiple myeloma with Dr. Kenneth Anderson from Harvard Medical School and the Dana-Farber Cancer Institute. Dr. Anderson, would you like to introduce yourself?
Yes, thanks very much. I'm Ken Anderson from Dana-Farber Cancer Institute and Harvard Medical School. And I've had a long-term interest in multiple myeloma going back over 4 decades. And I'm very honored to be here. I think the extraordinary progress in myeloma is really an example for many cancers. And these forums allow us to make sure that patients can really be exposed and take advantage of all these advances in real time. So honored to be here today.
Thank you, Dr. Anderson. And Dr. Carol Huff from Johns Hopkins University and Hospital. Dr. Huff, would you like to introduce yourself?
Yes, thanks very much. My name is Carol Ann Huff. I'm from Johns Hopkins in Baltimore. I too have had a long history with myeloma, but not as long as Dr. Anderson. I'm very honored to be here today and hope that this podcast will help our providers throughout the world help our patients take advantage of the therapies and understand better how to apply these and how to ensure that all patients have the best access to novel treatments.
Thank you, Dr. Huff. And last but certainly not least, Dr. Shaji Kumar from the Mayo Clinic in Rochester. Dr. Kumar, would you like to introduce yourself?
Thank you, Lauren. My name is Shaji Kumar. I'm a hematologist at Mayo Clinic in Rochester, Minnesota. And my interest is all plasma cell disorders and specific interest in developing new treatments and looking at the mechanisms of disease progression. And it's a great honor to be here with Dr. Anderson and Dr. Huff.
Wonderful. Thank you, Dr. Kumar. Our first question, considering that there is no established optimal sequencing of novel therapies in the relapsed and refractory settings for multiple myeloma, how do you individualize the sequencing of CAR T-cell and bispecific antibodies for these patients based on patient and disease characteristics? And then, where in the disease course should CAR T-cell therapy and bispecific antibodies be added? And what are your thoughts on CAR T-cell therapy before bispecific antibodies versus bispecific antibodies before CAR T-cell therapy in these patients?
Okay, I will start. I think that the excitement around these novel T-cell treatments is palpable. I think that as we have shown both for the CAR T-cells and bispecific T-cell engagers, there's remarkable activity even in patients who have had 4 or more prior therapies. And having these 2 modalities now moving earlier into the disease course presents wonderful opportunities and challenges for us. And the question is to define their individual efficacy and side effect profile, but also to determine whether there might be something important in terms of their sequencing. And so you're seeing all these studies that are now defining the therapeutic index of both the bispecific T-cell engagers and CAR T-cells, not only individually, but also in combination. Could it be that if you use one prior to attempting the other, you could be, in so doing, impacting the efficacy or side effect profile? And we don't really have the answers to these questions. As is true with pretty much all the treatments we've had in myeloma, we start in very far advanced disease and move earlier, and it already looks like CAR T cells, first in patients who had 4 or more prior therapies, have now been recently approved and are being more effective in patients in earlier lines of disease after only 1 or 2 prior treatments. And so the trend is happening for the bispecific T-cell engagers. I think the very early data for both modalities is exciting, but what it does suggest, albeit very early, is the use of the bispecific T-cell engagers prior to CAR T-cell treatment may have an adverse impact, and it may be in early data advisable to consider using the CAR T-cell approaches earlier and saving the bispecific T-cell engagers for later. I hasten to add, I think we have only minimal data supporting that at this time, so we really need to have clinical trials. I finally would say that as excited as I am about these new T-cell based therapies, because we're achieving unprecedented responses where there literally were no treatments just 1 or 2 years ago. The excitement is palpable, but I think we really owe it to patients, to our medical community of providers, and to the payers as well, to demonstrate the efficacy in randomized objective clinical trials, which are ongoing, before we adopt them. And these trials will not only say whether they're effective, but they will help us in terms of sequencing in this particular issue, whether it's wiser to use a bispecific T-cell engager before or after a CAR T-cell therapy, or even in combinations. That all remains to be seen from clinical trials, but it's a time of unprecedented opportunity for patients and caregivers alike.
Fantastic. Thank you, Dr. Anderson. Dr. Huff, what are your thoughts on this topic?
So I would agree with Dr. Anderson. And I think that, what I often will say to patients and to others is, with every exciting new therapy we probably have 20 more questions that get asked about this. And so our early data showed the wonderful activity of these agents, the depth and durability, and now the natural evolution is, where do we use them? How do we sequence them? What are the combinations? And I fully agree that we need the results from randomized trials. We do, from mostly real world data, from some small aspects of trials, have some hint that, as Dr. Anderson said, that CAR T cells followed by bispecific antibodies may be superior to the other aspects of things. And, there are scientific reasons why this may make sense from T-cell utilization with the bispecific antibodies on an ongoing basis, how much time apart, etc. We don't have that information, and we really do need it. And both for our patients, for our payers, for our medical community, these therapies are wonderful, but they are costly, and we just need to be judicious in making sure that we're doing them at the best time in the best combinations for our patients.
Excellent. Thank you, Dr. Huff. And last but not least, Dr. Kumar.
I cannot agree more about what has already been said about the bispecific antibodies and the CAR T cells. We have a lot more to learn, particularly in terms of why patients or the disease becomes resistant to some of these new therapies. We already seen some of the information from the phase 3 trials that we can use the CAR T cells early on at the time of the first relapse and get meaningful benefit compared to other treatment options. But this is a fast evolving field, and given that myeloma is a disease that we hopefully in the future, but not yet, can consistently say that we are curing patients, we need to utilize all these therapies in a very judicious manner in order to maximize the benefit that patients can get out of each treatment. To that extent, I think there are the ongoing trials that Dr. Anderson mentioned are looking at, where can we place these new therapies? So there are trials looking to see if the bispecific antibodies can either replace an element of the combinations we use for newly diagnosed myeloma, or can we add it to the existing treatments? Can we replace the autologous stem cell transplant with either CAR T cells or a defined duration of bispecific antibodies? And one of the important questions that is for the field is, how long do we keep treating patients? And we are currently looking at a paradigm where patients are treated for a very long time until disease progression. And can these immunotherapies be leveraged to allow patients to get more limited duration of treatment? Now, obviously, efficacy is important, and we see that the efficacy of the CAR T cells drop after the bispecific antibodies, and to some extent, the same thing happens in the other direction as well. But the good thing is that we have new bispecific antibodies and CAR Ts being developed that are looking at antigens or proteins which are different than what is being targeted with the current generation of bispecific antibodies and CAR Ts. So hopefully by using either a different target for these immunotherapies, or by using a combination of two immunotherapies that targets two different proteins at the same time, like what we have seen with, for example, the combination of two different bispecific antibodies, we can really get very deep responses in patients who might not have gotten a significant benefit from either one of them used alone. So I think the key in the future is going to be figuring out where in the course of the disease evolution do we use a particular therapy. Do we use one before the other, or do we replace one of them with a different one targeting a different antigen, or use them in combinations? So a lot of questions, few answers, but I think what we have learned so far certainly sets the tone for future research and gives us some directions as to how best we can leverage these drugs for the bettering the outcomes of the patients.
Wonderful. Thank you, Dr. Kumar. Does anyone have any final thoughts or key takeaways on these topics for today's podcast?
I would say this is exciting times for myeloma. We're certainly seeing a lot. Patients are clearly living a lot longer compared to what we have seen in the past. But I think it's up to the myeloma community to figure out, why do some patients eventually become resistant to these therapies, so that we can continue to improve upon them.
I would say also it's an unprecedented time in multiple myeloma. Clearly, people have more options than ever. I think the obligation is for both of us together, the patients and caregivers, to determine the relative efficacy and also the sequencing of these novel agents. We need to do this in an objective manner, and then once we've established efficacy, we really need to then make sure that access to these advances is equal for all of our patients.
I would agree. I think that what all has been said today has been wonderful. We really have a burgeoning field of even more therapies. And while we're talking about CAR T cells and bispecific antibodies today, there are cell mods and other agents as well that need to be factored into this. But I couldn't agree more that access is key, and we need to make sure that these are available to all of our patients in an equitable manner, and that we can ensure that the knowledge and the availability is there to ensure that everyone with myeloma has equal access to these wonderful advances.
Thanks so much, Dr. Kumar, Dr. Hoff, and Dr. Anderson for sharing your expert insights with us on novel therapies for the treatment of relapsed and refractory multiple myeloma. And thanks to our audience for tuning in. We hope you found this podcast to be valuable for your practice, and we look forward to having you join us next time.